Do you struggle with teaching in the busy clinical setting? I know I do. I'm Lottie Derby, Director of Faculty Development for MSGME. Take a few minutes right now to hear what Dr. Margaret Dow, a well-regarded educator, has to say about using the one-minute preceptor model to teach in the busy clinical setting.
My name is Margaret Dow, and I'm an assistant professor of medicine in the Department of Obstetrics and Gynecology here at Mayo Clinic, Rochester. I'd like to talk about a quick and easy method of approaching clinical teaching called the one-minute preceptor model. This model was introduced by Kay Gordon and Barbara Meyer at the University of Washington School of Medicine and has been adapted to a wide variety of clinical settings and academic projects to improve medical education. This is one of my favorite mechanisms for clinical teaching. It's quick, easy to invoke, focuses your teaching as well as the learner's takeaway messages, and can improve clinical care while maximizing your teaching efficacy and efficiency. There are 5 steps, or micro skills, in this model. First, get a commitment. Most learners will pause after they've presented the subjective and objective data that they've gathered. This is your big moment. The easy approach is to jump in and give away the answer. You might try, however, to get them to arrive at an answer. A simple question like, "What do you think is going on?" will usually suffice. Sometimes in the inpatient setting, the diagnosis is made, and this step becomes less useful. Secondly, probe for supporting evidence. Ask why and how they arrived at their answer, and what supporting evidence they considered. Depending on the setting, you may also ask about other diagnoses they considered, and what supported or refuted these ideas. This step is still useful in the inpatient setting when the diagnosis is already made and can help you assess the learner's scope of knowledge. Third, teach general rules. This is where we share the wealth of our experience. The goal is not to focus on the rare case or outlier, but to share a useful, evidence-based clinical pearl or two about this particular complaint, diagnosis, or in the inpatient setting, treatment. The fourth micro skill is to reinforce what was right. For early learners, this may be simple reinforcement of their improving presentation skills or ability to gather an adequate history. In a senior level learner, you may be able to remark on the collection of data that help distinguish between 2 possible diagnoses. If possible, tying this reinforcement to how it affected a good treatment plan or outcome is useful. Finally, the 5th micro skill is correction of mistakes. It may help to gather from the learner how best they accept feedback, and you may find it useful to do this privately at the end of rounds or at the end of the day. Utilizing a sandwich approach of telling what was right, correcting mistakes, and providing input on how to improve next time increases the likelihood of learner acceptance of feedback. Now we'll run through a quick example so that you can see how efficiently this can be used. Let's say your junior resident gives you the following presentation. A 25-year-old woman presents to the emergency room with right lower abdominal pain of 1 day's duration, currently 8 out of 10. Tylenol and Motrin have not helped. She's been eating normally until the pain became overwhelming, has no fever or chills, and has had a normal bowel movement this morning with no nausea or vomiting. She's healthy with no medical conditions other than class 1 obesity and has never had surgery. She's never been pregnant that she knows of. She thinks she may be starting her period today and is bleeding a little. She can't remember when her last period was. She doesn't smoke, drink, or use any illicit substances. She has a new boyfriend, and they use condoms sometimes. She works at a fast food restaurant, no history of bowel disease or pain syndromes, and she's never had anything like this before. Your first micro skill? What do you think is going on? Well, I thought maybe it's just irritable bowel. Your second micro skill? Why do you think this? What else did you consider? I thought it could be her bowels since she works fast food and doesn't have a fever, but it could be appendicitis since it's in her right lower quadrant, or even an ectopic pregnancy. Third skill jumps in now. Teach the general principles. In this patient, she reports being sexually active without regular contraception. An ectopic pregnancy is the most dangerous of the diagnoses on the differential and must be ruled out in any young woman who's sexually active with lower quadrant pain. In fact, and here comes the pearl, any woman of reproductive age with emergent abdominopelvic complaints should undergo a pregnancy test as part of the workup, with follow-up studies as indicated. Fourth, reinforce what was right. I'm glad ectopic pregnancy made your differential. It could be catastrophic to miss. With just a simple sexual history, you identified that this patient is sexually active and not reliably using contraception, which puts her at risk. Fifth, correct mistakes. Irritable bowel is a common diagnosis, but it's not likely to present this acutely without some previous history of similar events. You correctly identified that appendicitis was less likely given her lack of fever and anorexia. I'd like you to read up on irritable bowel syndrome and its presentation. So to summarize the 5 skills that you can use this quickly: get a commitment from the learner. What do you think is going on? Probe for the supporting evidence. Why do you think this? Teach the general rules, 1 or 2 clinical pearls. Reinforce what was right, and correct mistakes, and recommend ways to improve. By applying these 5 microskills to a teaching situation, you'll help your learners make the jump to committing to their thought process while allowing for continued learning and improvement. Thanks for listening to this quick tutorial on 1 Minute Precepting. I hope you gathered some easy skills to bolster your teaching.